Well, good evening, and thank you for joining us again for Learning with National Leaders. This continuous virtual speaker series is presented by Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis. I'm Carol Daniel, your host. September is Ovarian Cancer Awareness Month, so we chose to center tonight's discussion around not just ovarian cancer, but all gynecological cancers, as well as fertility preservation. We'll be focusing on treatments, the importance of screening, and some critical efforts that women can make when it comes to prevention. I want to start with some important statistics when it comes to gynecologic cancer. In 2019, there were more than 200,000 women living with ovarian cancer in the United States. This year alone, the American Cancer Society estimates that nearly 20,000 women will receive a new ovarian cancer diagnosis. Ovarian cancer ranks 5th in cancer deaths among women, which is largely because ovarian cancer often has no symptoms and because it often goes untreated until the disease has advanced. The survival rate is low. In fact, it has a 5-year survival rate of only 50%. However, a woman's risk of getting ovarian cancer is rare. Only 1.3% of women will be diagnosed with ovarian cancer at some point in their life, according to the NCI. Now, let's introduce our panelists joining us tonight, our 4 Washington University experts at Siteman Cancer Center, and I told them that they are experts in case they didn't know it when they walked in this evening. So let us start with Dr. Lindsay Kuroki, who is a surgical oncologist, Dr. Stephanie Markovina, who is a radiation oncologist, Ann Geiger, a genetic counselor. Ann Geiger is a nurse practitioner, I should say, and Rachita Nikam, who is a geneticist. We talk often about genetics when we talk about cancer. So we want to start with a simple discussion about what we need to do and what we should be thinking about. Thank you all for coming. Let me say that, first of all, for being with us this evening. It is so glad to have you. And a reminder to those of you who are watching, we definitely want to hear from you. You can submit your questions right here on the website, and we'll try to get answers for you throughout the evening. Dr. Markovina, let's start with you. Let's talk about some of the most common types of gynecological cancer, and what is the typical age range of women who are diagnosed?
Great to be here, Carol. The most common type of gynecologic cancer diagnosed is endometrial cancer by far. The typical age range for that is above 60, so generally an older population of patients. Then ovarian cancer, as you mentioned, approximately 20,000 women per year will be diagnosed with ovarian cancer. That occurs in slightly younger patients, so on average 50 to 60-year-old women. And then the third most common is cervical cancer, which includes about 12,000 new diagnoses per year, women diagnosed with cervical cancer per year. And that can happen in younger patients, so anyone between the ages of 30 to 50 is most common.
We talk a lot. Every time we get together, we talk about screening. So tell us about screening guidelines for those cancers you mentioned.
Sure. So one of the most well-established screening procedures of all cancers is cervical cancer screening. And that involves a pelvic exam with a pap smear and looking for abnormal cells on the cervix, sometimes also with HPV testing or human papillomavirus testing. That's recommended for patients between the ages of 21 to 65.
That's a wide age range. Mm-hmm. Because it is so important in diagnosing cancer, speaking of screening, what should women know about being screened?
So if you fall within that age range, I'd encourage you to talk with your doctor. So if you see an OBGYN regularly, that's the best doctor to talk to about these screening procedures. But if it's a primary care doctor, ask them about that. They should be bringing it up as well. It's recommended on average between every 3 and 5 years, and exactly what that screening is will depend on your particular situation. So I'd, again, recommend discussing it with your doctor. And that can involve, as I mentioned, both brushings of the cervix itself to look for abnormal cells, and then also new tests to detect the presence of HPV virus.
We talk so often about whether a test is uncomfortable, not wanting to know, so we don't get screened in the first place. talk about how the screenings actually work. We want to get real tonight and take all the mystery out of it so that there is no fear whatsoever.
Absolutely. So unfortunately, it does involve a pelvic exam, which for many women can be uncomfortable. That's really important both to be able to feel the cervix, to see the cervix, and to take those samples that we can look for abnormal cells or the HPV virus. It is extremely effective, however, at detecting early stage cervical cancer and even pre-invasive cancerous changes to be able to increase the chances of cure from that cancer. So very important and effective.
And a reminder, friends that are watching us tonight, you can submit your questions and we will try to get answers to those throughout the evening. Dr. Kuroki, let's turn to you. With so many types of cancers that we're talking about and treatment options for them that they have clearly improved over the years, what are some recent advances that we should cheer on right now?
Good question. I feel like there's so many things that have been developing over the last few years. And to highlight just a few, we mentioned it was Ovarian Cancer Awareness Month. To highlight some of the advances for ovarian cancer, first are the FDA has approved 3 oral chemotherapy drugs that have been shown to be beneficial to women following a diagnosis of ovarian cancer after they've completed surgery and chemotherapy. That has been showing very promising data to extend the amount of time they live without cancer. And this is exciting for women because, you know, part of all the underlying reasons we were looking into these targets is because molecular testing is now offered and recommended for all women with an ovarian cancer, not just their blood to help screen, as we'll later hear from my colleagues here about genetic testing, but also the molecular testing of the tumors. And so we're getting smarter. We're really excited about offering women these tests that can actually make a difference in their survival. From a cervical cancer standpoint, I think, you know, there has been new FDA approvals for immunotherapy, which can be combined either with combination of chemotherapy plus or minus a targeted therapy. And, you know, to have these options for these patients with metastatic or advanced stage or recurrent disease, it just opens up options for these patients that really never had options before. And so this is a very nice opportunity to make sure that we're profiling these tumors to make sure we personalize our cancer therapies as much as we can. There is exciting data in endometrial cancer that also looks similarly at these targets for immunotherapy. But as we gather across the nation, I think there really is a race to really offer molecular testing upfront and early so that we can, in some cases, actually de-escalate care so that we're not exposing women to unnecessary toxicities that might not impact their survival. So I think in all different realms of GYN oncology cancer, we're certainly making smart strides. We're using research to help improve outcomes for our patients. And I think across the board, we're very much recognizing the disparities that exist among certain populations, that we need to be mindful of some of the problems with access to care, access to gynecologic specialists, to radiation oncologists, to genetic counselors. And so it's just a really exciting time in general.
In all of my years of reporting on cancer and cancer research, targeted therapies was not there. I will say that I am 60 years old and have been a reporter for, I don't even know right now. But the truth about it is that targeted therapies, that was not a phrase.
Yeah.
That was not a thought, at least in the public's mind. Talk about research, and that is one that we've seen come to pass, but talk about the other research that is going on right now.
Some of these research initiatives are really being pushed through the NCI, through our cooperative groups, internationally and here in the US. And like you said, there's a lot of combination targeted therapies that's getting pushed in new drug developments. And I will also say, as a early investigator in research, there's really mindful initiatives to include early investigators in mentoring so that we continue to lead the field and know how to develop and to innovate and to include equity in our research initiatives. And for an example, this past year was the first year that the DoD, or the Department of Defense, actually offered funding for endometrial cancer research in addition to ovarian cancer research. So I think we're getting recognition as a cancer disease that deserves funding, and I think we're slowly moving the needle on all of our cancers.
You definitely strike us all, I think I'm safe in saying, as a hopeful person.
Yes.
That's just in your DNA, and in all of our medical professionals' DNA on the panel tonight. What does make you hopeful when you talk about research and targeted therapies and access?
You know, I think what makes me most hopeful at the end of the day is always sitting across from the patients and their families, and their fight is as much as our fight together. And I think that community and that acknowledgement, you know, I was actually just saying before that Dr. Markovina and I usually are participating in a multidisciplinary tumor board right now. And that sense of united multidisciplinary efforts to really gather the most diverse opinions for one patient's care, to individualize their outcomes, look at their pathology, to get all the specialists in a room and really provide as much comprehensive care that we can. That is what makes me hopeful, that we're continuing to work hard, that we're reaching out to the community with all these specific efforts, and that the patients and their families are celebrating these things with us. We have a lot of community efforts in St. Louis, including Pedal the Cause that's coming up for Siteman. So I definitely think my hopefulness is shared by a lot of people in the community.
Certainly, that's so great to hear, because when you hear the C word, and I have heard the C word, the cancer word, you no matter who's in the room, you feel like you're alone. And so to realize that you open your eyes, you're not alone, that makes the patient hopeful. So it's really important to know that our doctors are hopeful. And we did mention NCI twice, National Cancer Institutes. We just want to make sure that you know what we're talking about. Rachita, let me go to you. We all know that knowledge is power. That is why we have these series of discussions. Knowing your family history obviously is a part of that, so that you can make the right choice for yourself and change your future. Talk about that when it comes to cancer prevention.
Sure. So genetic counseling is much like this process. It's a conversation. It essentially is a way for us to help our patients not just understand, but adapt to the medical, familial, and the psychological implications of a cancer diagnosis, or be a family history of cancer. So talking to a genetic counselor, doing the genetic testing, can lead a patient to the knowledge that they need to make the right decisions for their care or their family's care in the future.
Talk about the process of genetic testing. How does it work?
So traditionally, it always used to be a physician referring the patient to the genetic counselor, us talking to the patients regarding their personal medical, oncological, or family history, and then leading the patient to testing. But like Dr. Kuroki mentioned, with the advent of targeted therapies and precision medicine, things have changed quite a little bit. Patients can get point-of-site testing at the time of diagnosis, or patients can try to get testing on their own. There are a lot of direct-to-consumer tests available. A word of caution, though, make sure that any test that you get is CLIA or CAP approved, which is, it's a clinical genetic test. There are a lot of imposter tests out there.
Oh my. Is there an age? We're getting a question about, is there an age that one should consider, or their doctor will be looking at them saying, you're the right age for genetic counseling, or is it the condition?
Well, it's not just the age nor just the condition. We see patients from all walks of life. We see patients pre-diagnosis. We see patients treatment post-diagnosis. To answer your question regarding age, I would suggest that women, especially with a family history of ovarian cancer, because September is Ovarian Cancer Awareness Month, with a family history of ovarian cancer should consider talking to their doctors about genetic testing and counseling prior to the age of 30, because it has a lot of implications regarding, especially if we find a significant pathogenic variant, regarding fertility preservation and then preventative surgeries and management.
So for women watching, if their mother's been diagnosed and they are under the age of 30, they should consider this?
Definitely.
For women watching, if you are under the age of 30 and your mother's been diagnosed with ovarian cancer, you should consider genetic testing.
Definitely.
All right, I don't mean to sound so serious and such, Debbie Downer right now, but we just want you to get the information. Does genetic testing include all family members?
Well, it could include all family members. We have had sessions where we talk not just to the patient, but their family members together. But because we discuss things like your personal medical history and reproductive history, some people may not be as comfortable discussing things with everyone around them. So it really depends on the patient's level of comfort. We have done individual sessions with patients. We've done group sessions with patients. It works both ways.
I can only imagine how emotional it can be.
It can be very emotional, but it is good work, and it can lead to really great outcomes for our patients, especially the ones who don't have a diagnosis. Preventative management and preventative care has improved leaps and bounds over the past few years. So I share Dr. Kuroki's hope that a multidisciplinary approach in our patients' care can lead to better patient outcomes for everyone.
Because knowledge is power. It might be emotional, but knowledge is power. Definitely. So as a genetic counselor, tell us about any link between family members who've been diagnosed and how common that actually is.
Well, to quote some numbers, Carol, about 5% of endometrial cancers and about approximately 10% of ovarian cancers have an associated inherited predisposition. So when you have a family history, especially of ovarian cancer, regardless of whether or not you've had negative genetic testing prior, it still has an implication for your personal medical risk. There are certain things you can do. So I would recommend anyone with a family history of gynecological cancers to talk to their OBGYN about these risks. And in addition to that, if there is any kind of cancer diagnosed under the age of 50, that is another trigger that should lead you to talk to your providers.
Any?
Any.
Because we were going to talk about inherited cancer risk, and that's where that statement comes in, correct?
Definitely.
Talk about inherited cancer risk.
So when it comes to gynecological cancers, a lot of females focus only on their family histories of breast, ovarian, or endometrial cancers. But as we have studied genetics more, what we are realizing is that the same gene can be associated with a lot of different types of cancers. For example, BRCA1 and BRCA2 are the very well-known, mostly famous genes that most people are aware about. And with those genes, yes, there is a risk for female breast cancer as well as ovarian cancer, but even beyond that, men who have these pathogenic variants can be at an increased risk for prostate cancer. Men and women both can be at an increased risk for pancreatic cancer and melanoma. And there are things that one can do to prevent those risks. There are screenings that one can pursue to prevent those risks. So yes, I do say any cancer diagnoses under the age of 50.
And so we definitely want to talk a little bit more about reducing one's risk of gynecologic cancers. How do we do that?
That is, so that's a loaded question, because that's a lot of different things one can do to reduce their risk for gynecological cancer. When it comes to genetic risk for gynecological cancers, depending on which gene it is that we identify, we are able to give our patients with specific risk figures of how much their risk is increased as compared to the general population. And depending on how much that risk is increased, that leads us to the management guidelines for our patients. So it all differs based on the patient's individual genetic test results as well as the patient's family history.
Great information. Can we bring you in, my dear? Dr. Kuroki, for those who have not been screened, can we talk about common symptoms that we should be aware of?
Yeah, so for ovarian cancer, I always tell my patients these symptoms are actually very subtle. So most of the time, they're so vague that most patients brush them off. They can include a little bit of nausea, a little bit of feeling full after they eat, a little bloating, changes in their bowel movements. More women probably experience a little bit more constipation or trouble having bowel movements. And then overall just not feeling well, not having the energy that they normally would have on a day-to-day basis. But unfortunately, as Dr. Markovina mentioned early on, ovarian cancer patients, the majority are diagnosed at advanced stages. And so although these symptoms might have slowly progressed over time, the majority, by the time they reach our offices, they are very symptomatic and they don't feel well. And we do oftentimes catch these in advanced stages where the cancer has spread not just from the ovary, but also in their abdomen and sometimes even to their lungs and manifest as shortness of breath.
It's almost like a whole nother conversation has to take place with what you just said, because we as women, we brush it off. And I'm having a hard day at work. The kids are doing fill in the blank. I just ate something that, and we just chalk it up to so many other things. Yeah.
On the flip side, endometrial cancer is often caught on the earlier side because vaginal bleeding is often abnormal. And especially for the menopausal women that have experienced all, cessation of their periods, all of a sudden have a little bit of pink spotting or a little bit of vaginal bleeding. And oftentimes weight is a big risk factor for especially our endometrial cancer patients. So fortunately, the majority of those patients present early. We mentioned cervical cancer screening already, and just as a reminder, screening in general is for women that don't have symptoms. So like you mentioned for this question, when symptoms arise, especially for cervical cancer patients, they often have pain in their pelvis or in the vaginal area, either watery or abnormal discharge or heavy vaginal bleeding. Some patients present with lower back pain or painful intercourse. And that often is, all these symptoms are manifestations of where the disease has spread, unfortunately.
Let's talk about reducing risk.
So when we oftentimes get results back from genetic counselors, we have an amazing opportunity to provide risk-reducing surgeries for our ovarian cancer patients that might have a BRCA mutation. We might be able to provide a risk-reducing hysterectomy for patients that have something called Lynch syndrome, that are predisposed for a uterine cancer. But in terms of cervical cancer, actually the most effective way to reduce your risk is to get the HPV vaccine. It is a prophylactic vaccine, which means it is most effective before exposure to the human papillomavirus. And it's shown to be very effective and the only opportunity that we have for a preventative vaccine for any of our gynecologic cancers. The other important follow-up to that is just to get screened for cervical cancer. We know that women that reduce the risk the most for this specific cancer type are those that are vaccinated and that routinely follow up with their doctor to get their screening tests, and then are able to follow up appropriately if that test is abnormal.
I know you've had this conversation before. Parents regarding the vaccine are thinking, am I just saying to my kids, go ahead and have sex, you've got the vaccine? I'm sure that you've had to address that, so let's address it tonight.
Let's address it.
Yes.
So, as a GYN oncologist, this is an opportunity and should be viewed as an effective way to protect your kids against cancer. And not just cervical cancer, as was mentioned before, this is an opportunity to protect both men and women. And effectively, we should be targeting those at age 11 to 12. But the HPV vaccine is available for anyone 9 to 26. And then with counseling and appropriate discussions with providers, people can continue to get the vaccine covered up until age 45.
And that's a misnomer, I think, because the initial rollout was get your children.
Yes.
So one can be in their late teens and 20s.
Yeah.
That's good to know. More information for you. That's what we do here. That's what we do. Doctor, can we talk about all the information that we're giving them tonight, and men who love them that are watching? We've talked about screenings. We've mentioned healthy lifestyle. We talk about always when we gather, and other topics when it comes to prevention. And I don't want people to tune out right now before you tell them what is like the most important thing that you want them to walk away with out of all the information that we're giving.
Lots of great information tonight already and to come, but I think just to reiterate 3 things that have already been discussed and emphasized already. One is cervical cancer screening. So it's the only approved screening approach for gynecologic cancers currently. So see your doctor, make sure they're ordering and obtaining those screening tests. The HPV vaccine, it really is the only thing you can do to truly prevent cancer development. If you're eligible, go get your HPV vaccine. If you have children who are eligible, have them vaccinated. And the third thing is to listen to yourself. You know, I think that some of the discussion of what symptoms do these cancers present with might be things that we don't think a whole lot about on a day-to-day basis. But if it's something that's happening that just doesn't feel right, talk to your doctor about it, you know, and really listen to yourself. And I think that's probably the best thing to walk away from this with.
Good stuff. Thank you. Thank you so much. Do we have a question? They're gathering a question for us. All right, so prior to last weekend, this is one of our questions. My last menstrual cycle was 4 years ago. They've never been diagnosed, but they assumed that it was early menopause. Should they be concerned? That's a great question. Ladies, who wants to jump in there on that one?
Well, I think a lot of that depends on the age of this person too. And, you know, early menopause isn't so specific, but if we're talking about somebody in their 30s, yeah, I would recommend definitely going and seeking follow-up for that, because, you know, your menstrual cycle isn't just your period coming, you know, every month. It's also representative of the hormone milieu that's going on, and estrogen's really important for other things that it's besides ovulation and menstruation. It's important for our cardiovascular health and our bones, and we want to make sure estrogen levels aren't kind of low at a time that's too early. That can have other implications kind of later on in life.
Anna Geiger, ladies and gentlemen.
Jumped in there.
So, wait, but you've taken me totally off script, because the attitude that we have as women, girls, about our period is it's this thing that comes and it tells me that I am not pregnant. It tells me in some families, oh, you're a woman now. But everything you just said is not what society is telling us as women about our period.
I feel like we have so much to learn about our periods. You know, I think the education for women on what your cycle really means is kind of, we're underserved when it comes to that. But yeah, it definitely means a lot more than what you just said. And I think it's really, I always tell patients, it's an important vital sign to pay attention to, because irregularity, you know, across the lifespan at different, you know, ages can signal something important medically that needs follow-up, whether that be early menopause or PCOS. And so it's super important to keep those conversations going with your OBGYN, important to, you know, make that annual, even if you're not necessarily getting a PAP. Our periods are important.
So we know that women are delaying childbirth, so we want to talk about that as it pertains to preserving fertility. So if you are waiting, and my second child, I was 38, I think. I have a friend who just had a baby, she's 40. We know that gynecologic cancers affect a significant portion of reproductive aged women who want to preserve their fertility for a future chance at childbearing. Let's talk about that. What is fertility preservation, first of all?
Yeah, that's a great question. Even though it sounds kind of self-explanatory, fertility preservation is sort of this term that refers to efforts or interventions that can be recommended where the goal is it's geared towards increasing your likelihood of being able to procreate in the future, so have genetic offspring. It's really important for our patients with a cancer diagnosis or some genetic diagnosis of an increased risk of cancer, because you may be faced with treatment recommendations, whether that be surgery, radiation, chemotherapy that could be introducing known risk or unknown risk to your future fertility. So fertility preservation is super important to discuss with your provider if, what are your options to preserve your future fertility.
What are your options?
Yeah, that's great.
What are the options?
So it kind of depends in terms of the kind of cancer realm, your age, specific diagnosis, stage, what's an appropriate intervention in terms of fertility preservation for you. Is that fertility sparing surgery for an early stage endometrial cancer? Or is it egg freezing for a patient before they're going to initiate cytotoxic chemotherapy? It's really case by case, but there's definitely many different options.
I feel like your big sister here. You're all, I think, younger than I am. I don't want to assume anything, but none of us might remember a time when a cancer would occur and childbearing was not even a thought. You just have cancer, you're not going to have kids. Oh, well, that probably was how things used to be. Now we have a different understanding and a different goal, a different passion and mission. Why is it so important?
Yeah, I mean, I think we're lucky here at Siteman. It's something that the physicians have so many medical things to talk about in an appointment where you've been diagnosed with cancer. We're very lucky that fertility preservation becomes one of the things that is touched on and that we offer here because it is important. It's important psychologically. I mean, a lot of patients are not done with their family building at the time of a diagnosis, and studies show it can have such a positive mental health impact being able to offer them that option. It increases this sense of hopefulness. It really can have such a positive impact.
We're going to take some questions. Are there new advances that you would like to mention?
Yeah, so there's always interesting scientific advancements that are coming down the pike in terms of fertility, things like in vitro maturization and lots of sort of fancy sounding things. But I'll say one thing I think would be important in terms of an advancement in fertility is expanding insurance coverage for fertility preservation. It's definitely seen as something that's elective medically, and I think that could be a really great, important advancement for our patients.
Jefferson City, Missouri, are you listening? That's where our state capital is. We're talking about lawmakers here. We have some questions here. This one is, if I have a history of ovarian cancer in my family and am in prime childbearing years but not ready for kids yet, should I look into fertility preservation?
So I think this is a question that both Anna and I can handle together. To answer the first part of the question, which is that family history of ovarian cancer and being in childbearing age, I would genuinely recommend any patient with that family history of ovarian cancer to talk to their providers or a genetic counselor, because with the presence of a genetic variant, the options for you as a patient are going to be very different as a patient with just a family history and no known genetic predisposition. So the age at which you need to make actionable changes in your life changes depending on what your genetic composition is, and that's how it leads into the next part of the question, which is the fertility preservation and what age.
Yeah, because it's not something that is always the easiest sort of process to go through when we're talking about egg freezing, for somebody who wants to do fertility preservation. We're talking a few weeks of injectable medications and a surgical procedure. And as I mentioned, it can be expensive and not always covered by insurance. So we definitely have to make shared decision-making with the patient, follow the medicine and the science, and sort of weigh when are we at that inflection point where the risk is going to outweigh, and tip the scales.
Our next question is from an individual who says, I'm interested in cancer genetic testing due to family history, but my family lives in other areas. Is genetic testing available via telemedicine? It's a great question.
That is a great question and gives me an opportunity to tell all our viewers and all of our patients in the Missouri and Illinois area that yes, we do see our patients via telemedicine. We do it over Zoom, we do it over phone, and if some patients do absolutely insist on wanting to see us in person, we do see our patients in person as well. For patients who do not live in Missouri or Illinois, there are other genetic counselors in the United States, and if you want to call us and ask for information about other genetic counselors in other states, we do provide you with that information as well.
All right, our next question. What are types of preservation offered for women with cancer? Does Washington University offer egg freezing?
Yeah, that's a great question. So we do offer egg freezing and also egg or embryo freezing. So egg freezing for those patients not partnered with someone who makes sperm, embryo freezing just referred to combining eggs and sperm. And then we're also really lucky to be one of the few institutions nationally able to offer ovarian tissue cryopreservation, which is a pretty cutting edge procedure where part of or one ovary is surgically removed prior to cancer-directed therapies that may be introducing this fertility risk. And that is cryopreserved either for future auto transplantation or in vitro maturization, like I talked about before.
Does insurance cover that?
You know, we find tricky ways to make it less expensive than egg freezing sometimes.
I love it. We find our ways to do it. Here's another question. Is there any data that conditions like endometriosis, uterine fibroids, are genetic conditions, I should say, and do they present more risk for cancer?
I could tackle that one.
Yes.
So there's not necessarily a very specific genetic condition that ties and links those specifically to a gene that will run in families. And polycystic ovarian syndrome was part of that question as well. Interestingly, though, I think it is commonly that patients find that somewhere in their history that their mothers or their grandmothers have also experienced similarly those things, but maybe just don't come up in conversation. There are endometriosis-related cancers that we often diagnose for ovarian cancer patients. And we know that because of the unopposed estrogen that women make when they have polycystic ovarian syndrome, it does increase the risk for endometrial cancer because that extra estrogen can stimulate the lining of the uterus to undergo changes that is a risk factor for cancer.
This has been fascinating. Is there anything else that you guys would like to add to send us off?
If I may just add to Dr. Kuroki's answer, though uterine fibroids are very common in the general population, if you have uterine fibroids and a family history of renal cancer or kidney cancer, that can be indicative of a specific genetic condition. It is not as common as BRCA1 or BRCA2, but if you have that gestalt of symptoms, it might be beneficial to talk to someone.
Wonderful. Thank you so much. That wraps up our discussion tonight. I want to thank our panelists for taking the time to join us this evening. I had to put my shades on so I can see what I'm saying here. Thank you to Dr. Lindsay Kuroki, Dr. Stephanie Markovina, Ann Geiger, and Rachita Nikam. Thank you so much for your time. You have been amazing, so informative. We really appreciate it.
Thank you.
So make sure to sign up for our next Learning with National Leaders discussion. Our panelists will join us to talk more about breast plastics. You can start signing up for that event tomorrow by coming right back here to this site. Meanwhile, we invite you to visit yourdiseaserisk.com. Let me tell you, I did it this evening. And what you do there is you will go on the website, you'll learn about your risk of 12 cancers and other chronic diseases and get personalized tips for preventing them. As always, thank you for joining us. Knowledge is power.